All right, now I would like to officially welcome you to our third installment of our webinar series entitled Medicare's New Conditions of Participation, Are You in Compliance? In today's session, we'll focus on infection control and QAPI, and it's my pleasure to introduce our speaker. Sharon Litwin is founder and senior managing partner at 5-Star Consultants. 5-Star Consultants is a national consulting and coding firm specializing in home care and hospice services since 2003. Sharon is a former ACHC and CHAP surveyor, performing Medicare Dean surveys for 10 years. Sharon has been in the home care and hospice industry for over 25 years. In her consulting firm, Sharon assists home care and hospice agencies in providing quality, meeting regulations, ICD-10 coding, OASIS, and increasing outcomes and star ratings, and having continued survey readiness. Sharon is a regular speaker to education companies, state and national associations, and publications. And with that, Sharon, welcome, and I'm going to turn things over to you.
Thanks, Patty. Hi, everybody, and thanks for joining me again today for our third part of our series. Well, I think that after you've heard the first two parts, you know that the key thing is that if you don't embrace change, you're going to have a really tough time. And I think that that's not too hard for all of us to do that are in home health, because when you think of all the changes that we've had over the years, over the decades, if you don't embrace change, you just can't be in our industry. Of course, there's so much change in any of the healthcare entities across that whole continuum that I think to be a healthcare worker, we sure have to go through a lot of change. We've been in business for 15 years, and we started out with an original motto of the only constant is change, because so much was changing in 2003 when we started. And it's kind of funny, we still keep that as one of our, it's like a banner across the top of our website and our displays, and it has never changed. The only constant is change. Well, today's session, especially QAPI, can really help you deal with that change, can help you. Okay, do you spend your whole day putting out fires? So many of you are answering yes. You leave work exhausted, and then you think as you're driving home, what have I really done today? I'm so tired. I was busy from the time I stepped in till the time I walked out. I still have stuff to do. I never got a lunch break, yet alone a bathroom break. And what did I accomplish? Well, I've been doing QI, QA, QAPI, whatever, since the late 80s when I was in a hospital system. I was actually a critical care director for a hospital, and our system had hospitals all over the country, and they picked 2 of us from each hospital based on how we did throughout our survey, and we had to go set up the very first QA, quality assurance programs, when they came into existence for healthcare formally. And ever since then, I have realized that if you have a good quality program that's not just busy work, that's not put on the back burner, but is an integral part of your operation, it puts out those fires, and then you can be more productive with doing things that you thought the job was going to be and really progress, whether it's with good case management or, running the QAPI program, increasing your census, working with your staff more, etc. Because the fires go out because you're addressing problems that will fix things in the long run. Your staff are involved, your competency of everyone is very high. And so if you think of QAPI as not just something you have to do because now Medicare says you have to do it, but in that aspect that it's going to help you be more satisfied in your job, you're not going to be as stressed out, and it pretty much puts you in continued survey readiness. So there's so many reasons to embrace QAPI. If you are accredited, you pretty much know what the QAPI standard means, the QAPI condition means. If you're not accredited, and in Florida, that would probably mean you've been in business for a long time and are not accredited, or maybe, but may not be, then if you're not accredited, you probably don't have a lot set up that's in the QAPI condition. But although I was a surveyor for 10 years and I did a lot of surveys in Florida, and then we do so many mock surveys, especially this past year, and a lot of accredited organizations are not compliant with what they have to do with QI for their accrediting organizations. A lot of agencies make it a lot of people make it much harder than it is. Honestly, I teach a very simple method of QAPI that I say is on the KISS method. Keep it simple, stupid, because we are too busy. If you have huge amounts of data, huge statistical programs, a lot of times they're great, but the agencies have no time to drill down and do something with them. So hopefully when we get off today, you will have a good idea of how to set up your QAPI program and a lot of examples. And then, of course, infection control is part of QAPI, so we will go over that as well. Well, as you know from our session on Tuesday when I talked about a lot of gray areas, we still don't have our final interpretive guidelines or a lot of clarifications. I will get Patty's answers to the questions that we ran out of time for on Tuesday, and I will also put some information that I got from Mary at NOC on the plan of care and on the aid. But honestly, it's no information. She has no more information. They've been trying like crazy to get answers from CMS, and no one's been able to get answers. So a lot of those black and white areas are still I am so sorry. A lot of those gray areas will remain gray for a while, and you just have to, like Patty and I were just talking about, you really have to do your due diligence to show that you have attempted to find out what exactly is expected from you. And that can be by, of course, me, Patty, and Bobby, and Monica at MOC, from NOC, Mary and Bill, from ACA, from your accrediting organization. And hopefully we will have some black and white answers pretty soon. Okay, so QAPI stands for Quality Assessment Performance Improvement. You would suspect it would be assurance, right? Because that's what it's been called for a million years. But about 10 years ago, if you know hospice, the new hospice COPs came out. And boy, I sure don't remember the pain and trauma from the hospice COPs as they are this time for our home health COPs. But it might be like having a baby. You totally forget how that felt back then. And they started a condition for QAPI in hospice, and they titled it Quality Assessment. So also, you know, since so much of our QAPI indicators, quality indicators, come from data-driven OASIS assessment items, that's probably why it's that as well. So I've told you a little bit about my history in quality, and honestly, it has changed what they call it so many times over the years it isn't even funny. QA, QI, CQI, TQC, PI, and I could put many more acronyms I've run into over the years. Then, of course, CASPER, that was in 2003. So we added that, which was the first data-driven information that we had. I have been teaching that a whole lot and doing analysis for agencies on that a whole lot since 2003. However, many, many, many agencies have not paid close attention and really utilized that data until now with the star ratings and value-based purchasing, when it took on such a high level of importance. Interestingly, if you're not a long-termer in our industry, in 2003, when CASPER started putting out the OASIS outcomes and benchmarking to the nation, and Home Health Compare started benchmarking to the state as well, that was for pay for performance. What you guys are suffering through with value-based purchasing, that was supposed to go into effect in 2004. And maybe for HCAP, it was called AHIF back then. I probably taught about pay for performance and how to improve your CASPER outcomes. That never came into play, and a lot of agencies ignored it. And now that's what's happening, and that's why you have to work so hard on your CASPER outcome reports and the star ratings and the value-based purchasing. This all ties together with a CoP program. All right, so I told you how a good CoP program should be one that is integrated through your agency, not assigned to one person, and not done as busy work, and certainly not that you wait till the last second. I can't tell you the numbers because they're way too high of calls we get from agencies we've never heard of or that we helped maybe get started up 3 years ago, and many from Florida. And now the call is, oh goodness, can you help us with our QI or now our CoP because we're due for survey? Well, sure we can. That's one of our niche areas. We can help you. Okay, well, we haven't touched our QI program since our last survey 3 years ago, and now our survey's due in 2 months. So what we need for you to do is catch up all our QI as quick as possible, but at least in the next couple of weeks so that we can get ready for survey. Honest to goodness, I just laugh at them. It is not possible to do that. Number one, that shows that they don't know that CoP does take a lot of time. And number two, what good is that? Even if someone has the time to catch up the last 3 years, honestly, what good is that? You're wasting your time on all of that old stuff. Now, you're going to look at some old stuff because you want to say, you know, what could we have done to prevent that emergent care for fall with injury on that patient last year? But other than that, you know, you want to show trends. You want to be able to show what you've done with those trends and how you are showing measurable improvement. So if you've ever been in that situation, it's very important to know that. And if you're an owner or a leader of an organization, CoP cannot be put on the back burner. You will not pass this condition if it is, and you will suffer in a lot of other conditions. The standards are relatively easy: program scope, program data, program activities, performance improvement projects, and executive responsibilities. So we'll go over each one of those, and I will explain and point out things that are really crucial that I always see agencies missing. So the program scope, you have to be at least capable of showing measurable improvement. So that's where we're going to stop at first, because that's huge. We have many clients that we do quarterly clinical record review, for example, and we do the clinical record review. And in fact, we have several Florida clients that we've had long-term, and we do those, but their goal is 90%. Well, not, and you know, we set that up, 90% is fine. But, you know, if you're 90% compliant as your goal, that still means you're 10% non-compliant, right? So you could get deficiencies even when you're 90%. But of course, with CoP, very rarely do you say you have to be 100%. Now, if I send you your quarterly clinical record reviews, just the overall one, not talking about each quality indicator, and they are 75% for this quarter, and I give you all the findings, which says why they're 75%. You didn't have enough physician notification, you weren't following physician orders, your meds weren't updated, your aides weren't following the aid care plan, et cetera, et cetera. Give you those specifics, give you the trends, help you with an action plan of what you're going to do to improve. Okay, so now next quarter, you send us what we're to review for the quarter. We do it again. It's 77%. And then the next quarter is 68%, and on and on. The problem with that is that you're not showing any measurable improvement. You are going through the steps of quality indicators, and you can show action plans every quarter, and you can show the findings, but you are not going back to the drawing board and saying, why are we not improving on our clinical records? So even though you may have a whole program in place, it is not an effective QAPI program. It is a paperwork program only. You are not showing measurable improvements, and that's non-compliant. So I spend time on that because a lot of agencies do not know that, do not understand that. You have to focus then on indicators where there's evidence that improvement improve health outcomes, patient safety, and quality of care. Sounds like a no-brainer, right? Well, I was in New York last week, and it was a very good agency. And one of the things I was doing, was looking at their QI program. They're not accredited, never have been, but they have set up a QAPI program over this last year so that they're prepared. It was very process-based. So in other words, it was the old days of QA before you really had outcomes and before you really looked at a lot of outcomes. And so it was basically, to just make a simple example for you, a piece of paper that says, was this in the chart, was this in the chart, was this in the chart? It was almost solely a clerical review. So it wasn't looking at any critical thinking of what was the coordination of care and the plan of care for the patient to improve outcomes. We're not there anymore. If you had to do a QA or QI program even several years ago and you were state and not accredited, that would be fine. But we are very outcome-based in the healthcare industry now. You should know this more than I'm talking to a lot of agencies doing this webinar because you've been on value-based purchasing pilot. But I know from having a Florida agency who's our client who just went through survey, many of our other agencies, actually one was lucky, they went through survey at the end of December, so they didn't have the new COPs, but you should understand how important outcomes are because you're in a value-based purchasing pilot program. That's what it's based on. That is what your quality indicators are. Your quality indicators, that term has never changed since I have been doing QA. That is just what you are going to measure in specifics and very objective. And I will show you lots of examples and give you samples at the end. You have to measure, analyze. That is a key. A lot of agencies do a lot of record reviews on different areas, and it stacks up, and either nobody understands how to analyze it, they don't think that's important, or they don't have time. That's the most common reason. And so the data stacks up of what they're measuring, but nobody has analyzed it, trended it, and taken it from there to say, what's our plan of correction to achieve measurable improvement in our patient outcomes? That is probably the key. So what I've just talked about over the last 10 minutes with this one slide on program scope is the key to your QAPI program. The last sentence I didn't hit is also very important. Your quality indicators have to cover all of your processes of care, your services you offer, your operations. So maybe you don't think of timeliness of documentation as related to outcomes, but it certainly is. Because if you have, like the agency I was at last week in New York, they had a very big issue with their timeliness of getting their OASIS time points and 485 time points done and locked. And that 485 out the door, they were very late, but they didn't even think that they were late. They had a goal that was way too many days. And in essence, unless you're telling that physician every single detail of what is on that plan of care, which you know that is not done. For those of us who work the industry, that is not done. You're in essence working without physician orders then. And so many other things. You can't file your RAP. I mean, there's so many issues with compliance and financials, denials because you don't have the 485s back, et cetera. That has a very big impact on your patient outcomes because it's holding up that whole plan of care process. If you do IVs, that should be a quality indicator. That's very high volume, it's very high risk and problem prone, whether it's low volume or high volume. Your wound care is a very high volume, high risk problem prone area. If you do, with your aid services and your therapy, it's very easy to do quality indicators that hit everybody because you're looking at your statistically significant outcomes on your CASPER outcome reports. I'll get all into that later if that's all Greek to you that I'm saying. And so by working on improving ambulation, improving bathing, so many of those outcomes, you're going to hit every service that you deal with because it doesn't just apply to one discipline. So in other words, it has to be an all-encompassing program to reflect what your agency is. Your data, you have to use quality indicator data, which includes, keep in mind, it doesn't say only from OASIS. That's the OASIS outcomes on CASPER and Home Health Compare. It's not only there. We're also going to look at quality indicators from your other high volume, high risk, problem prone areas. Maybe wound care, maybe, IVs, pediatrics, whatever. All right. Everything has to be done that you're collecting data on to monitor the effectiveness and safety of services and quality of care, and of course, identify opportunities for improvement. This all has to be approved by the governing body. You have to ensure that your QAPI plan, your QAPI indicators at the beginning are all approved by the governing body, and then go to the governing body regularly with your results and trends and action plans, etc. Now, you've heard me say already a lot, high risk, high volume, problem prone. Since I started Equality in 1988 and it was brand new, that has been a key term or sentence or whatever. That has never changed. That's what quality indicators are based on. Now, like I said, maybe you don't do a lot of IVs. They're not high volume. But man, that makes them even higher risk because you don't do them often. Are your nurses' competency? Do you have a good coordination of care program going on? Do you know the standard of care for IVs? So you have to look at the incidence, prevalence, and severity of problems in each of those areas. Wounds are very high volume, and you might think, oh my goodness, our wounds are fine. But 9 out of 10 of the home visits that I make for mock surveys still, and it was the same when I was doing real surveys, of wound care done, the infection control techniques for wound care and the following orders for wound care is not good. And so that is always a problematic area that you should be looking at. So that's how you identify various areas. You always have to take into account and take immediate action to anything that could lead to harm or has caused harm for a patient. That's immediate jeopardy. But that's more serious than saying, oh my God, we're going to be in so much trouble, our agency's going to be shut down. You could be harming a patient. So when you are starting quality indicators, if I do one record review, as I did about 3 weeks ago, on one IV, it was the very first chart that I looked at for one of our long-term agencies that about every year they have us do a check. And the very first chart that I reviewed was an IV one, and it was a mess. And it would have been immediate jeopardy had I been a real survey and not a mock surveyor. And so those are the things, you just hold the phones right then. I don't go on to chart 2 and compile this and tell them that in the findings. I get on the phone immediately and I say, we have a real issue. You need to get all the staff that are on this case in here, and we need to powwow about this and see what's going on and fix this. So you always have to jump on those immediately. When you find them yourself and jump on them, you do a lot of documentation. That's going to turn into a performance improvement project. You're going to do a root cause analysis, and I will give you tools and samples at the end on those. Okay, so I told you how many times the terminology and the buzzwords have changed. So even the condition on CoP flips around a lot. So now performance improvement activities, it's the same wording, quality improvement, quality assurance, whatever. It has to track adverse patient events as well, analyze their causes, and implement preventive actions. So, you know, of course, that's med errors. That could be falls. It's a good idea to put that. So all of the ones that you always have had to look at as far as adverse patient events. The agency has to take actions aimed at performance improvement, and after implementing those actions, the agency must measure its success and track performance to ensure improvements are sustained. Remember, I had said at the beginning about measurable improvement and that example of the 75% for every quarter for clinical record reviews. You have to make that go up. So let's say that I have a conversation with the administrator about that, explaining that you have to improve. You can't just say, we're okay with 75% every quarter. And, oh, we try, we hit our heads against the wall because nothing ever gets better. I hear that all the time. Well, that's not good enough. Okay, so let's say your method of making sure it improves after I have this talk with you is to call a meeting and go out there and yell at everybody and say your documentation is awful. Sharon said that we're always at 75% chart reviews. You have to make that be better. I'm hitting my head against the wall. You guys got to get on the stick or else. Okay, so that's your method of improving it. The next quarter, I review it, and lo and behold, it's 88%. Great job, administrator. Okay, good. You're working the action plan. You got that up. Next quarter, I review them. They're 72%. What the heck? Well, this happens a lot. You go out, you get mad, you yell at everybody, say this is what you're going to do from now on. You're going to submit everything in 24 hours. Supervisor, you're going to review this in 24 hours. You're going to get this corrected, blah, blah, blah. Okay, that works for a while. People do it for a while, but you haven't really changed anything. You just yelled at them. That wears off after a while. You forget about that and you move on to other things to yell about. So each time that gets bad, you have a hissy fit, people do stuff for a while, and then it falls off. That is known as a sawtooth pattern in quality. 75% one quarter, 90% the next quarter, 72% the next quarter, 85, 65. That is a sawtooth pattern if you graph it on an Excel graph. And it shows you don't really know what you're doing. It shows that you are not making real improvements. You're just doing a knee-jerk reaction to get the scores up, and then there they go again. So you can't do that either. You have to improve them and sustain them. They have to stay improved. And any time that they're not, you have to go back to the drawing board and do a new action plan. So these standard performance improvement projects, now don't be misled. Now, first of all, I need to change that date, although this is another gray area. They haven't said for sure, but they did say when the draft IGs came out that the date will probably be July 13th, 2018, that we're only having 6 months to get these performance improvement projects in place. And that is because they already gave us a delay in the COPs, which gave you time to put your plan in place, start collecting data on your quality indicators. But you would be starting a performance improvement program if you have a good QAPI program in place way before any kind of deadline, because of the fact that well, let's use the bad IV example that I gave. Let's say it wasn't an immediate jeopardy, but it was a very vulnerable condition level deficiency you'd get, and you need to take immediate action. Well, in that case, you're not going to wait to do a performance improvement project. You're going to do it now. You're going to get the staff in the room. You're going to get the home infusion company on the room. You're going to look at your competencies of your IV staff, your policies and procedures. You're looking at a lot of things in order to fix a big problem that involves more than one M item with OASIS knowledge deficit. This is where you have to do a lot of things, have task forces, have meetings, make phone calls, change processes to improve something that's important. So that is a performance improvement project. If you've been around for a long time, we've used PIPs forever. It's never really changed. It's when you find a problem, you do a PIP. That's what this is. But with our QAPI program, you always have to have one going underway annually. So you do what I said. You find quality indicators that you are not coming up to goal, and you realize that it's complex and it's a high-risk area. It could be PTI&Rs. You find out that, gosh, there were med errors because patients and caregivers were giving the wrong doses after a PTI&R and a physician's order to change the Coumadin. That's kind of a common one because it's incredibly problematic with all of the entities involved to make that happen. And so as you track your med errors, you see a trend with Coumadin errors by the patient and caregiver after Coumadin changes. That can automatically turn into a PIP because you have a lot to look at. The thing is, if I come in as a surveyor, I want to see a lot of documentation on that. So don't just have meetings, say you dug into everything, you fixed everything, and that was your PIP, but you can't have anything to show for it. All of those things I'm talking about that I gave examples of PTI&Rs and Coumadins as well as IVs, you want to have a lot of documentation. So this is in a little binder, and it is called the PIP, and it's with your QAPI stuff, but you can break it out and show this. A lot of times PIPs will include a root cause analysis, like I said. Okay, and you show in that documentation why you're doing this project. That's pretty simple. What has the measurable progress been? So if you start one today and your survey is in a couple of weeks, you're just going to show, okay, here was the data that we found on this. Here's why we're starting this project, and here's our first meeting on it with what we think we need to do. But if they come in 8 months, you're going to pretty much show them the measurable progress you made on that one. That's all a performance improvement project is. Please don't wait a long time, no matter if we have to have these in place July or next January, because as you do a good QAPI program, you usually have several PIPs going on at once. Your E-standard is executive responsibilities, and this is really all about having the governing body be the head of this QAPI program and being involved all the time. They're making sure you have an agency-wide program that's looking at patient outcomes, looking at patient safety, looking how to improve on all of that. And in addition, number 4 is any findings of fraud or waste are appropriately addressed. Well, when you're doing a QAPI program, it's very easy to see things like we see all the time. I mean, my goodness, in our coding division, our RNs are doing OASIS and documentation reviews on a daily basis. So let's say they're reviewing your research. And every research that I'm doing to do coding and then give you OASIS and documentation recommendations, I am seeing no skilled need documented, none at all. And in fact, I don't even know if it's just documentation. I think maybe there is no skilled need. I think you're just going to keep an eye on the patient. So that could be potential abuse, not fraud, and abuse. But if it goes up the line at, to the OIG, it's looked at as fraud and abuse if you keep patients on that have zero skilled need for research, that as an example. So that all has to be reported to the governing body as well. And of course, how you appropriately address them. You may be saying, we found out that we have a lot of research that there is no skilled need, so we had to have a lot of education and change our processes so that now our clinicians are talking to the clinical managers with all the disciplines involved on taking care of Mrs. Jones and really seeing if there is skilled need in order to decide if we're researching or discharging. That's a part of this too. So that's all that there is in the actual condition. It's very simple and short if you just read it through, but you can see as I pulled out so many words in each of the numbers, it's an awful lot you have to understand. If you don't have experience and weren't taught in CoP at all, a lot of times it's Greek, and that's when agencies get on the wrong track with the CoP program. This is a lot of information I'm not going to go over, except for one, but it's here for you to read. It's from our Federal Register with our COPs in it, the final rule responses, answering questions about, well, are you going to give us specific forms of what we're going to do? No, this is for you to come up. The last quote in this one, though, hospital readmissions and emergent care need to be considered by the agency. If you are in a value-based purchasing state and you haven't been having quality indicators on hospital readmissions and emergent care, you need to add those immediately because those are very highly weighted. They're probably the most important outcome in my mind because Medicare says we allow for Medicare home health. We pay for it. We pay billions for it. And the reason we do that is we want to keep patients out of the hospital and out of the ER. Well, if home health isn't doing that, what good are they? I mean, that's basically what they're looking at because financials, right? And they pay us while that patient's in the hospital. Well, that's not our fault that they're paying two places, but they do. But that's one of the things that they look at. If you weren't in a value-based purchasing state, what I teach is any agency that's even close to the national benchmark, if you're 1% over the national benchmark or even 1% under on hospital readmissions and emergent care, you should be doing a good quality indicator on both of those. The reason why, even if, let's say, the hospital or the nation is 10% on readmissions, and let's just say Florida is also 10%, and you are 9%, you're saying, well, why in the world do we have to review all these charts on hospital admitted patients and take all that time when we're better? The reason is agencies are working very hard to get these percentages down because they know that the agencies that can do this are going to be the long-term viable agencies. So if you sit where you are at 9% and now the nation gets down to 8%, then you're going to be in trouble. Now, I got to tell you, when Casper first came out, those numbers were a quarter of the patients in home care, and sometimes up to a third were being readmitted and going to the ER. Since agencies work on that part so hard to keep their patients from having to go back in, those numbers have dropped dramatically. Now, we have a lot of different outcomes for hospital readmissions and emergent care. We have the outcome-based, we have the claims-based. We have the very specific ones in the claims base that are very important, such as emergent care without hospitalization in the first 30 days or 60 days. They're really zeroing in. So if you don't have a quality indicator saying, did we front load visits on this patient? Did we have good coordination of care with the team? Did we do very early physician notification A lot of areas that you can really, really work on in your agency to reduce emergent care episodes and readmissions. And, you know, we've been very successful in working with agencies to bring that down. And these are agencies that will start off where the clinicians and the management say, there's no way we can do this. You don't understand. Our docs here say, send them to the ER. Well, then, you know, I look at charts and I see that maybe the PTA, I'm picking on a discipline, the PTA 2 weeks ago documented in the visit note that the patient had more swelling in her ankles and was more fatigued today. So she didn't walk as far and they did more sitting home exercise program. And that patient has a comorbidity of CHF. So if that, okay, that's documented, that's great, but it doesn't go anywhere from there. What if that PTA had let me, the RN, Bob, the OT, Mary, the aide, that's those of us who are taking care of Mrs. Jones. What if that PTA had let us know that right then? Well, maybe Mary, the aide, can say, oh, and also I wanted to let you know she was more short of breath during her bath today than normal. Well, now, me, the nurse, maybe I was going to go see the patient in 2 days, but now I'm going to go see her today or in the morning. And maybe I find that, ooh, yes, she has a lot more swelling, fatigue, a little bit of rails. I'm going to call the doc. I'm going to get an extra dose of Lasix. End of story. Everything's good. But in this scenario, the PTA saw that. Some other documentation was seen by the other disciplines over the next 2 weeks. And then, boom, the patient was hospitalized with a when I told the staff and the clinical, the ER all the time, and the fans pick up the phone and call 911. But by the time I got done talking to them all about this after reading the chart, it was obvious that there was no coordination of care, that nobody was being eyes and ears for each other. They weren't talking, they weren't identifying early CHF symptoms so that interventions could be done right away. So when you're looking at quality indicators for admissions and emergent care, there are many things you can do to get that down. That's a huge part of QAPI. This is about more tools and private pay and more flexibility. But this one, if you want more information on all those, you can read those. But this one is if you're part of a system. Whether it's a big hospital system, a SNF system, or a chain of home health agencies, be careful that you are not just relying on the system quality program, because they may be focused on something that, yeah, that's great. You have to, if you look at the third paragraph I have there from the final rule, this is an example they give. The system-based program is really focused on all things that relate to infection prevention and control. But the agency's historical area of weakness is effectiveness of OT in achieving desired outcomes. That could be based on IADLs in the risk-adjusted outcomes being low. That those are typical OT areas and maybe some of the ADLs. Why do we have an OT in there, but the outcomes aren't going up? So we know that from our CASPR and then from digging into that. So now we need to have a quality indicator on that that's really going to look at those outcomes that are related to OT that are not improving and what to do about them. So you have to make it very specific to your certified agency. It can't be a general program. I, did a lot of surveys on a chain, a big nationwide chain for a lot of years, and I would find that all the time is that what they showed me for their QI programs, they had an awful lot of indicators, a lot of statistical information, but none of it was related to the challenges I found in their agency. So know the rules. This is not out of the COPs or CMS, this is from me. But rules are, you must include your contracted services. So in other words, that is in our new COPs an awful lot of times, how your contracted services have to be part of QAPI and infection control and coordination of care and the emergency preparedness program. Do not overlook that. That is going to be a very high piece of a survey, is seeing how well Bob the PT and Sally the OT are coordinating care with me on an ongoing patient on our patients, how they know what indicators we're working on based on our outcomes and what we're doing about them. They know what our emergency preparedness program is, and on and on. You must focus on quality indicators related to improving outcomes. You must focus on the use of emergent care and readmissions. You must focus on high-risk, high-volume, problem-prone areas. You must focus on all things across the spectrum of care, including prevention and reduction of medical errors. And you must be capable of showing measurable improvement in indicators and sustaining the improvement. If you print this slide off and hang it up, that will help you with things that you can say, uh-oh, we're not doing that piece. So to build a successful QAPI program, if this ever loads, there we go. I don't know why that took so long to load. I can't move it till then. So where do you start? I'm actually giving you a handout and quickly going through a 4-hour course I teach on QAPI. And so I didn't want to condense and not give the people that I do a 90-minute on QAPI and infection control less. So you have a lot of information, and I'm just going to touch on each thing. But you can take it back, you can read it, start to understand all this I've been talking about, and have a basis to set up your foundation, as well as a lot of examples. So Casper and Home Health Compare, very big. I'll show different specifics on that. Obviously, how it relates to star ratings and value-based purchasing, so you're going to focus on those outcomes that you're statistically significant in. How do you select the measures? What do you do with them? How do you develop an indicator in an audit tool? How do you write an action plan? And what if we aren't improving? Okay, so the Casper outcome reports. Although this is basic, I have had a lot of calls over this past year where when I say to an agency, when they want us to help with QAPI, the very first thing I say, even if it's to go on a mock survey and not just QAPI, the very first thing I say is, okay, now that we're working together, send me your Casper outcome report. And unfortunately, even though these have been around since 2003, many times the answer to me is, or the question to me is, can you show me how to do those, because I don't know what they are or how to get to them. So number one, if you don't know, you need to find out immediately what Casper outcomes reports are, who is the dedicated person in your office that can get into that system, enter your certification number, and get into the Casper system to do this. Why is it called Casper? Just because that's the name of the software system. So back in 2003, that kind of stuck. CMS called it Casper. It's our outcome reports. You might know it is OBQI, just outcome reports, OASIS reports, but it goes way past the OASIS validation reports. It compiles like over 7 million patients OASIS time points in every 12-month period. It takes every M item for every patient from every agency for every OASIS time point and basically benchmarks it. It's an amazing system. What our outcomes come from, however, are 2 time points. It's either start of care to discharge or ROC to discharge. Notice that research not in there. Transfer is, I should have that in there, but we have minimal transfers. So it would be if they weren't discharged and transferred, you would just substitute transfer. But most of our outcomes come from discharges. So if you are looking at discharges as a quick and easy visit that takes 10 minutes, and so you schedule a lot of start of cares on me because I have a lot of quick and easy discharges, your outcomes are so skewed because I am not doing the discharge oasis assessment like the start of care assessment and ROC assessment was done the correct way, and I am just zipping through those M items. That means your outcomes are meaningless. It has to be done the same way. These are the 4 reports that we use all the time, and I tell you, I can analyze these in my sleep. I do so many of them, so this is the tips I'm giving you from somebody who's been doing this for years. Those 4 reports are very important, and I'll show you what's in each of those. Always do the 3-bar. That is a very easy tool to read that won't be as intimidating. It shows your current percent, your prior 12-month percent, and the national current percent. If you have an asterisk, it means you're statistically significant to prior period or national. That's what you want to pay close attention to. If you have 40 asterisks, you can't do 40 indicators at a time. So then you start prioritizing what's of those, what is a value-based purchasing outcome? What is a star outcome? What is a real problem for us? The agency patient care related characteristics report, a lot of agencies overlook, but this is a very important tool. This gives you your risk adjustment. So you want to ensure that anything that is statistically significant as far as raw scores on M items, therapy days, length of stay, your diagnosis, that it all makes sense to what your agency is doing. And why are you statistically significant in areas? Because if it's things you have power to change legitimately, that gives you better risk adjustment on your outcomes. So in other words, when you pull off your outcome report, it doesn't just say patient outcomes, it says risk-adjusted patient outcomes. So a lot of times I'll get questions saying, these outcomes don't make sense for us. They're not what we see actually. Well, that's because these are risk-adjusted based on this previous report, agency patient characteristics report. Again, the 3-bar. This is a very important report because it has your ADLs, your IADLs, your ambulation and transferring, important clinical ones, improving in meds, dyspnea, pain and development of UTIs, confusion and anxiety improvement, and your emergency department and rehospitalization. Don't overlook the claims-based ones that prints out with this. Your potentially avoidable events, or PAE, if you've been around for a while, this is our adverse events. I mean, they keep changing these terms all the time too, but they mean the same thing. These are bad things that happen that we don't want to happen in the future. So only for this report will you print out the patient tally. If you do the patient tally report for the others, you're going to be sitting in the queue all day because you're going to get all your patient OASIS data for the last 12 months and the prior 12 months. So only print out the patient tally on these because you won't have a lot of these. And you might have a dozen patients. And so then you look at what are statistically significant. Did you have a lot of emergent care for wound infections or deteriorating wound status that was higher than the nation and state? So now you review those charts. Don't review a chart from a patient that was at the very end of the prior period because that's 2 years ago, more than 2 years ago. Try to review in the last 6 months or so. Review that clinical record and you're basically saying, is there anything we could have done to prevent this? Also, development of UTIs, increase in number of pressure of ulcers, decline in oral meds, decline of 3 or more ADLs, DC to the community needing wound care, med assistance, toileting assistance, behavior problems, or unhealed stage 2 pressure ulcers. So you want to make sure on any of these adverse events that you are higher than national, or for the ones that are on home health compare, higher than state. You want to review these charts, do a quality indicator for more monitoring to make these go away so that you are under national. The process measures is what they were called for years, also standards for best practices. Now they're called PBQI, process-based quality improvement. Timely initiation of care, physician notification, risk assessments, all of yours should be at 98 to 100%. If you're lower than that, you need to see why those assessments aren't being done. All of the interventions in 2250 should be done as appropriate and then put on the plan of care. So if this is a no, you want to see why. Implementation, the same way. If you're answering yes to all of those on 2400 at discharge, then, you know, a surveyor is going to make sure you really did have documentation on diabetic foot care. I just saw a deficiency given on that last week in Florida by a surveyor because there was no documentation ever on diabetic foot care and patient education. Heart failure, symptoms addressed, medication issues identified in timely physician contact. To be able to answer all of those on discharge, you have to do a look back in the chart to see what things occurred over the episode of care in order to have integrity with your answer. So the agency has to have some good process in place for where me, the clinician doing the discharge, can easily look for that. If you don't have someone assigned to go into the Casper system monthly and check if it was updated, please do. It's always late, it's always old. Sometimes they update months at a time. As soon as they're updated from the last one you have, queue down those reports, print them or put them to PDF, and have whoever in your agency does the analysis of them, do the analysis, write an action plan, see what should be in a QAPI indicator, share with the staff all the time. If you don't include your staff in outcomes and QAPI, you're missing the boat and you won't improve. Quickly, here's Casper Home Health Compare. If you don't know that, there's a link to get into it. Anybody in the world can see it. This is where I think it's 14 measures. You're compared to your competitors, the state, and the nation, where Casper just compares you to your prior and to the nation. So you want to follow up on this. This is more detail on the kind of indicators you would select. I already talked about a lot of this. All right, very quickly, if your OASIS accuracy isn't good, your outcomes will be skewed. You have no clue what your true outcomes are. So an OASIS audit of your clinicians is a great first step. Definitely you tailor the education plan to that audit. Maybe Nancy Nurse is the one with all the issues with not understanding M items, but maybe everybody else is pretty good and just have a problem in one M item. So that's how you focus your education so you don't waste your time and you're really narrowing in to improve your outcomes. Don't underestimate how important doing a full OASIS class for all of your clinicians every year is. OASIS is difficult. It changes quarterly. It has an awful lot of intent and guidelines that let us actually have more leeway, and clinicians are busy and running around, and they don't have time to look this up all the time. So be sure a full OASIS class annually will help. Then you audit again, and then you start dropping off the percent and times of audit for your best performers. Consistency. If all of your clinician OASIS clinicians are not doing the assessment in the same exact manner, your outcomes are skewed. If they're all not doing a complete OASIS assessment at discharge, the way you do started care and rock, your outcomes are skewed. So I can teach an all-day class on this one. So just real quickly, you don't do things for the patient. You have the patient show you things. You don't ask the patient if they can go to the bathroom and take a shower and walk up and down the steps okay. You watch them doing this. You don't take off their shoes and socks to check their feet. You tell them to take off their shoes and socks and put them back on. You have them read their meds to you, describe the side effects, etc. This has to be done by every OASIS clinician at every OASIS assessment. Otherwise, your outcomes are skewed. You will never be able to improve outcomes if you don't know those answers. Because of time, and like I said, I gave you this full class, this self-assessment is nothing more than a mock survey where you're going to go through. It's basically what I do on mock surveys and what surveyors do. You are looking at what a surveyor does to drill down to see where your challenges are to make CoP quality indicators and to fix problems once and for all before a surveyor tells you about them. So first of all, the person who's doing the survey really has to understand what to look for. But now here is a list of what you review, how do you review it. For the home visits, very important to do home visits, but you have to know what you're asking, what you're looking for as far as when you intervene, what should be in the home folder, and what is a good infection control technique, for example. Your clinical record reviews, again, make sure the people that are doing them know what to look for. A lot of times we'll see agencies do their own clinical record reviews and have 90 to 100%, and when we do them, they're 60 to 70%, simply because they're missing the mark of what needs to be looked at. This just helps you in how to develop the CoP plan. But jump down to the bottom of the example. This is one of the first indicator examples I'm giving you. Development of a UTI, that's your quality indicator based on you had potentially avoidable events where you were higher than the nation. So you chose, and you saw trends that in your infection surveillance for the last 2 quarters, you have had higher development of UTIs than ever before. So your CoP coordinator will review 100% of patients who develop a UTI during the home care episode of care to ensure appropriate interventions, education, and infection control were performed. Your frequency is quarterly. Your goal is 90% compliance to the audit criteria. This means that we made an audit based on what we can look at to say what could we have done to prevent a UTI from occurring. Now, we measure to that. What's not on here that we would also include is where were we on Casper? Was our potentially avoidable event, were we at a 2% of development of UTIs when the rest of the nation was at a 1%? So your goal is going to be at or below where the nation is. So you'll have, in other words, 2 goals for every indicator when you pull them off of the outcome reports. I didn't put them all in here. Every quality indicator has to have a specific audit tool, and you really drill down in the criteria to make it meaningful. Another indicator example, heart failure symptoms addressed. The Director of Patient Services or designee will review 10% CHF patients per quarter to ascertain if answers to the OASIS question were accurate, appropriate, and have supporting documentation in the clinical record. I talked about this before. Don't just gather the data, do something about it. This is different methods of how to analyze it. But I'm going to go over in the next 5 minutes the action plan. Make sure your action plans are very specific so that you can drill down to the problems and correct them once and for all. Action plans almost always include staff education, process change, policy change, CoP monitoring, and PIP projects. So a lot of those will be in every action plan you do. Whenever you have an indicator lower than goal or significantly varies, you revise the action plan. Here's an example. This was a real life one that I did, and there were 8 patients I reviewed with wounds. In 6 of the 8 patients, the physician orders for wound care were not followed. Now, Then you have the list as in below the first chart, but you're going to have all 6. What specifically was not followed? Well, this shows how and what dates and what it was. So your action plan, this is an example. This is an important slide to print off as well, because often agencies really miss the mark on their action plans. QAPI monitoring, the DPS is to review 100% of wound care patients a quarter to focus on following physician orders with a 90% compliance. If after 3 months that goal is achieved, then we reduce it to 20% records a quarter with a goal of 90%. And then we have the audit tool that's designed specifically for wound care and this deficiency. The education, you don't just put in service will be done. Then you follow up and you document 215 by the DPS regarding physician orders for wound care. Then 3.1 by the wound care consultant regarding wound care types, because we realized that was an issue. And then the home visits with a wound certified nurse and nurses on all wound patients by the end of May. The process change we made was on all patient orders from 567 wound care clinic. The DPS will contact the nurse on the same day with those changes. Coordination of care, all wound care patients will have communication notes in the EMR by the clinician receiving new wound care orders the same day. For those of you who have had a deficiency like this in the past, you know that action plans, especially if you're accredited, have gotten this specific. This is how for mock surveys, we always write the action plans. And this is with the clients, of course, because you have to have a big part in this. And this is how every action plan for your quality indicators should be. This is a simple Excel sheet that has all of your quality indicators in the first column, then your frequency, then your goal. Then if you have been under goal, you put the results in red. If you're over goal, they're in black. A very quick calendar, benchmark, indicator sheet that shows your governing body and your office staff and your aides and everybody in between what you're working on and where you're at. This is information of what to do if you're doing a PIP project, performance improvement project. This is the root cause analysis. It's a fishbone analysis. You may know it by both. It's very important to use. You get stakeholders involved, means everybody involved in what the issue is, no matter what their position. Everybody brainstorms. You have the big Post-its up in the walls of the conference room, and next thing you know, your fishbone is full with communication, physician notification, coordination of care, documentation, process change, etc. If you get everyone involved, have a large QAPI team rotated every 6 months so that as you work through, every one of your staff is involved in brainstorming, doing action plans, reviewing indicators, etc. Guess what? Everybody's education level and compliance improves because you're doing it all as a team. It's not your QAPI coordinator. This is a QAPI loop showing QAPI never stops. You can look at that. It's an ongoing process. A checklist you can use to help you. This is a bunch of indicators and audit tools that you can help to get a framework for what you have to do for yours. QAPI is not new, it's ongoing, it's involved, but once you have a good program in place, you will not have as many fires come up every day. Notice that I didn't save a lot of time for infection control because there's not a lot to it, but it is a big deal that we have a condition for it now. The number of infection control deficiencies will probably soar because this was a catch-all before. You kind of stuck it in with compliance, federal regs, etc. And it wasn't written up as much as told to agencies, although infection control breaks in the home happen all the time. So you want a good program set up. It only has prevention, control, and education. It's actually nothing new. You can read the final rule responses about where to get different, from quality organizations, the data, because they're not giving us specific ones It would have been easy if they said, here's the CDC regs, follow those, but they don't do that. So you have to have a infection control program, which is goal is prevention and control of infections and communicable diseases. Of course we do. The prevention, you have to follow accepted standards of practice, including standard precautions to prevent the transmission of infections and communicable diseases. This is a no-brainer. It's something we've always done, except we're not compliant with a lot. And now it will be very easy for a surveyor to go right here and ding you if one home visit they were not following good infection control technique. B, control. If you're accredited, you're already doing infection surveillance. And honestly, maybe ACA has looked at this more, if I recall correctly. But this is basically, number one, you have an agency-wide program for this surveillance. It's an infection surveillance program. Identification, prevention, control, and investigation of infectious and communicable diseases that is an integral part of your quality program, your QAPI program. Well, I already reviewed that because development of UTIs as a quality indicator came off of our potentially avoidable events. We're doing infection surveillance. We also noted that we're not only high to the nation, but we've seen an increased trend in development in UTIs over the last 2 quarters in our infection surveillance program. You should have already been doing that. It is supposed to have been done before, although it hasn't been laid out in our COPs. You have to include a method for identifying infectious and communicable disease problems. You have to have a plan for the appropriate actions that are expected to result in improvement and disease prevention. It is a basic infection surveillance program. If you don't have one in place and don't know what I'm talking about, I put our 5-star policy for it. I don't even think it's the whole thing, so that you can kind of see what I'm talking about. The process sample is important if you don't have a good process. The big thing is that this also starts at the field clinician level. It is up to the field clinicians to identify all signs and symptoms of a potential infection on their visit. When they do, they initiate whatever kind of infection surveillance form or electronic form you have to say, okay, the patient's coughing, has a mild fever, you know, whatever. Now, part of what that clinician's going to write on there is that the physician was called because they think they're seeing early, hopefully, signs and symptoms of infection. So once the clinician calls the physician, has contact back or doesn't yet, and then somebody has to ensure follow-up, and once you find out what that infection is, even if it isn't confirmed by, you know, a urine CNS or something, if the physician says, yes, it's a URI and I'm going to prescribe amoxicillin, then that is what is put on the report that the physician said, yes, it's a URI. That's what we need to have done. We don't have to have the information from the lab results if the physician is telling us it is this type of infection and then hopefully prescribe something. If we don't know, it is a potential. If the doc said, if you're calling with cloudy urine and the doc says, tell them to get a UA, then you put potential UTI, you just put the symptoms, and then you complete that. This can be either the clinical manager, someone in the office, or the field clinician who completes it when we have the results and the orders. This goes to whoever then is collecting these all along, and then they are, you know, skimmed then. If it's something real bad, then you have to address it immediately. If not, it's put into the infection surveillance log for the quarter, and then at the end of the quarter, you identify if there are any trends. If there are trends, you take action. This is an example of our infection surveillance form. This is just a 5-star form. It's if you have no clue what I'm talking about, this is one of the millions that are out there. This is one of our trending and tracking examples. We have so many different ones of these for so many different agency needs. You put in the patient ID and then you post, the number for the infection type and the symptom noted, and was the MD notified and the antibiotic ordered. So this can be the trend sheet for the quarter, so you can easily see if you have high trends in one of those. Okay, so now C is the education standard. The agency must provide infection control education to staff, patients, and caregivers. Well, you already know that. You're already doing that. But I will tell you that you're probably very weak in your documentation of it. I see that always. I've been doing this for such a long time, and I see such wonderful infection control education being done for patients and caregivers, and then I open the clinical records and read the visit notes, and they don't give themselves any credit whatsoever. This education that you do every visit must be documented specifically, and that should be done by everyone seeing the visits, the patient every visit. Me, the nurse, Bob, the OT, Sally, the PT, and Mary, the aide, all have to be coordinating care and really documenting specifically what are we teaching about on all this? What are we following up on? What are we doing teach back to, so that the patient and the caregivers are telling us the infection control safety measures they're taking and how they are doing things to prevent infections. That's a very important piece. HHQI is such a good website, and it has a whole lot of best practice and teach back sheets for you to use for various quality indicators and PIP projects. It's HHQI. If you Google that, it'll come up. I never know the association of the affiliation. I think it's a contract with CMS that does home health quality improvement, but there's a ton of best practice information that you can use there. For meds and pain and ongoing, but a lot on infections. This is just a sample policy of areas that are hit in our patient education and our staff education. The key to good infection control is not just frequent in-services. It is frequent supervisory home visits with I'm saying supervisors, but it can be a field clinician who's excellent at it and has been trained. So whoever's doing the joint visits to do your home visits for infection control and following physician orders and patient rights, etc. But the infection control piece, be sure that the person doing it knows what to look for. We've run into a lot of problems over the years where an agency, like for instance, I was very close to this agency, actually doing interim management and then weaning down as I was training the director. I set up a QI program for them, just the way I'm talking about today, and the supervisors were to do home visits with 50% of the staff every quarter, and to look at a bunch of things, of course, infection control being a big part. But I had never seen the staff, even though I had known them so well. I knew they were good. I knew that their charts were getting better. Their QI was looking good. But every quarter, the supervisors would send the QI to us to compile and trend and write action plans. And the home visits were always 100% across the board, 100% compliant. Well, I've been around the block too many times to even believe that's possible. So the director and I decided the next time I come, I'm going to be there for a week and I'm going to do nothing but home visits. So I hit over 90% of their staff. We loaded the deck. We put vulnerable visits so that I went with all wound care for the nurses. I did like 6 wound care home visits, and then IVs, and then lab draws. And then I did with all the other disciplines as well. 100% across the board, there was infection control breaks with all the staff going into the bag for supplies without washing their hands. That contaminates your whole bag, by the way. And that is such a common thing. But if you teach it that way, that your whole bag is contaminated, if you go back in, not washing their hands before they're going to their pens and papers and their laptops, and putting their bag on a dirty floor. And then the nurses, terrible wound care infection control breaks. The nurses sat on the floor, their fields were on the floor, they were cross-contaminating, and on and on. I don't think that those supervisors were fibbing. I've known them for a long time. They're good people and want to do the right thing. But guess what it was when I talked to them and the director about it? That is the way it's always been done. They get a lot of stasis ulcers, a lot of patients that can't ambulate well, that are obese, that are diabetic, so the nurses plop down on the floor and do this stuff. So if you don't know for sure that the person who is observing the visit knows what to observe, you're going to have skewed answers and think you're doing better than you are. So this is a good time to make sure everyone that's doing home visits knows what to look for. And then you do the home visit as if you were a surveyor. You don't help the clinician. You watch them unless it's a safety issue. Here's one audit tool that we use for home visit criteria. Best practices for optimum infection control and prevention is educate, educate, educate. That means to staff, and that means to patients, and that means to caregivers. Patients, every visit, they should have something taught to them, reinforced, and the patient and caregiver are saying back. They're asking open-ended questions so that they have to talk about it every visit, and document specific. Give frequent infection control handouts, not just at your admission visit, because obviously they're not looking at that admission book every day. But if next week you give them a yellow piece of paper that has 3 infection control tips, they pay attention to that, and you keep on doing that, and it's going to sink in. That's the same way that you educate your staff. You make it frequent, and you make it in different methods. You do frequent in-services, but also you walk through home visits. You talk about competencies. You do competencies on infection control. And then, of course, your quality indicator on infection surveillance, as well as any outcomes and high-risk areas that are quality indicators for you. So infection control and CoP are new conditions, but for most of you, they're not new. It's just that now you have to really step it up and do a lot more probably than you've ever been doing for these. A lot of education, a lot of learning, and a lot of work to set, a lot of time and work to set up your first CoP program. Once you start it, after about the second quarter, it does not take as much time because everybody's more familiar with the concepts, and it gets easier as you go along. You set up task forces with your field staff to develop and then monitor every quality indicator is the best way to go. And then, of course, you have infection control stuff in there as well. Even if you're small, involve all your staff. They're going to be asked about it in detail. So you want them to be ready, and the only way they can be ready is to be involved, not because of a piece of paper you hung up on the bulletin board and told them about in a staff meeting. All right, so it's an awful lot of material, but I like to give you all that because I'm hoping that no matter what level you're at, you can take some of these samples and examples and tips and strategies to help you develop these programs and make them better. So I appreciate you being on the call today, and then we still have part 4, which is emergency preparedness plan, which of course I don't know why we're doing because you've all been in 100% compliance since November 15th, right? I understand how hard that one is too. So next week we'll go through emergency preparedness, I think compliance to the federal regs, which is just a little bit on labs, and then clinical records. So thanks for hanging in there.
Okay, Sharon, we have a few questions that have come in, so I'm just going to jump right into the questions if that's okay with you.
Yeah, sometimes I can see them. Right now I can't see them, so I'll just listen to what you read.
All right, so the first one relates to CoP, and they're asking if they need to have a policy and procedure related to CoP.
Yes, absolutely. A lot of agencies put the policy and procedure in and then think they're done. But on the flip side, you have to have a policy and procedure. Your policy and procedure is going to take the standards and basically write the standards in there and then drop in little bits about what you're doing. Your policy isn't going to be as specific. Then you're going to have a CoP plan. That's going to be in your CoP manual or folder in the computer. I call it manual so you know what I'm talking about. You have a binder. The first pages is going to be your CoP plan, and that's going to tell you a lot more information of how you're going to fulfill that policy. And then from that CoP plan, then you have a page that has all your quality indicators written the way I showed you, and then an audit tool for each of the indicators. And then your calendar, which shows a list of the indicators, frequency, goals. So first the policy, then the CoP manual with all that stuff in it.
All right, next question relates to the CASPR reports and sort of the timeliness of data. So we have one attendee that asked if the CASPR data is timely data, and another attendee had asked, how do you know what dates or periods to enter when running the CASPR report?
Okay, so first of all, on the timeliness, because it is related to star ratings and value-based purchasing, CMS has promised us over and over and over that they would be very up to date. They are finally fairly up to date. They just updated CASPR about 2 weeks ago. And I believe now it goes up to October. So that's pretty up to date because that's almost, they're never going to be immediate. And so a quarter behind is good. Usually they're so far behind and have been, which is hard, but they're still what counts. They're what Big Brother looks at. They're what surveyors look at. So you have current period that you see for nation and for you is actually to the point wherever it's been updated to. So let's say it was updated to October 2016. Your current period goes back to October 2015. Your prior period ends at 15 and goes back to October 14. So it's very old data. For a very long time, all we were able to do was run it that way, that you would get a full year. And so you go back to 2014. Well, honest to goodness, we don't care a lot about 2014 anymore. We have to move on, right? So now, when we just ran, for the client that I went to last week, they allowed us, again, to choose a period, which is fantastic. Now, the thing is, it's a rolling, continuing average. It takes a long time for scores to change. But if you are able to, and I swear the time frame on CASPR changes each time an agency tells me they get into it, if you can do the last 6 months, that seems really good to me because that is the nation over the last 6 months, from October 16, so back 6 months, and then 6 months back from that is a year. So you're actually seeing what happened with you over the year, how your prior period changed the first 6 months, the second 6 months to the first, and to the nation. So that's what I recommend if you're able to. If not, sometimes it just will give you that year, and that's what you have to go for. Sometimes it's let you put in whatever dates. And for that, I wouldn't just take the last 2 months. I would go last 6 months. Then every time it's updated, hopefully they're going to update it every quarter now. But look every month just in case. And then when it's updated, because it's on a rolling continuing average, you can just keep doing that 6 months back because then you're always going to have a year of data, but you're going to keep moving ahead. I forget the second part of it, Patty.
So they were just asking when they go to pull the reports, how do they know what period or time frame to pull the report for?
Oh, you can just put that date in, but a lot of times the drop down is locked or whatever, that it just gives you a 12-month period. But like I said, now it's a drop down that we were able to specify dates when I was in New York last week. So I think that they have changed that. So you'll just have to get into your Casper and see if the time frame they're letting you put anything you want, or if it's going to say the last 12 months. I honestly don't know, because it has changed a lot of times and I can't access it. I can only, if I'm in your office with you, you get in under your dedicated sign in under your cert number, and then I can look with you. But all I can do is tell you, once you're in the Casper queue, if you can pull the 3-bar reports for the ones that I told you, those 4 reports, and if you can choose it for the last 6 months, that would be perfect, because then you would get, the prior would be 6 months as well. You'll have a year data.
All right, now still on the Casper reports, Lori's asking, do they need to use the Casper reports for QAPI, or could they use reports that are generated by their software platforms, which have more recent data?
If you have those platforms, that is well and good, but you are expected to look at your Casper reports. And so maybe, you know, without naming names, I'll call it ABC, has an awful lot of data, has where they are comparing you. They are comparing you to their other clients for the most part. You want to go on Casper as well, and you want to make sure that you have the same data, because the surveyors and CMS are not looking at ABC software vendors' reports. They're looking at your Casper reports. So if there's a variance, you can talk to ABC and say, what would cause this big variance? Typically, when I work with agencies, it's because of the sampling. It's that, okay, we put you in the large agencies for your region, and it's of our clients. You want to be sure you are also looking at your Casper report.
Okay, and still on the Casper reports, we have 2 attendees that are asking about particular reporting items. First one is asking about potentially avoidable events report. Would they find that within the Casper report?
Yeah, it is. It is kind of confusing when you're in there, but honestly, last week when I was looking at it with the gal, I was showing what reports I wanted. It was easier to find than it's ever been before. So I'm thinking they updated to October, which is really good. They let us pick the time period, and I'm thinking that they worked on how easy it is, you know, to get to the report, because it's always been a nightmare. And like I said, it's impossible for me to walk you through because I'm not there with you looking at it. But it was easier. And so the 4 reports that I said, they're probably under. I think the first thing, once you get into Casper and put your information in, I think it's still called OBQM report. It might be OBQI report. It might even say adverse events, and that's when you go and you see potentially avoidable events. But I'm kind of remembering that it says OBQM or OBQI. So once you're in it, it should be pretty easy to be able to see what, you know, you're just going to click on the hyperlinks, and then it'll give you the list of reports. Just be careful, don't hit patient tally on each one, because it'll lock your computer system up.
Okay, so would that hold true for emergent care for falls? Because Linda's saying she's not finding that. She's wondering if that was removed from the report.
No, emergent care from falls with injury is still on our potentially avoidable events. And so even if you have a 0, if you print out the 3-bar, it should be there. They have put nothing out that that's been removed. They've made such a big deal about the flu and pneumococcal off of the VBT, but I was just, honestly, I was just doing a Casper analysis, and emergent care for falls was there.
Okay, next question comes from Lynn in relation to infection control. So she was asking, do you have a product that you recommend to wipe off a BP cuff and stethoscope that meets requirements, but does not require putting gloves on to touch the wipes? And she was also asking if it would need to be wiped after each time you use it on the patient, or only if soiled.
Okay, so to answer that last part, because I know that specifically, it is not just when soiled. You should be wiping it off when you use it on a patient. If you're using it frequent times on one visit, then I wouldn't. But I would definitely wipe it off after you use it. Some agencies are wiping it off at the beginning before they use it too, because they don't know where, it's that old saying, we don't know where that's been. So that probably would be my safety method of doing it. And also that we, had to redo all our policies for the new COP, so we really dug into a lot of this stuff. And I believe we got what the CDC says as far as what is to be used. And then that would make it that you have to just make sure, you're not just picking something up at Walmart that doesn't meet what it is. I can't remember, but I know we looked into that, and the only place we ever get stuff to update our policies is from CDC when it comes to infection control stuff. But you don't have to then put gloves on to use the wipe if they're yours. If they're in a patient's home, I probably would, and then you're just wiping off patient's stuff if you have wipes in there for them. Probably the best thing is to look at CDC. If your policies haven't been updated for a while in infection control, it really is necessary to update them, because I know our chapter on our infection control policies, we had to update a whole lot for our infection control manual based on the COPs and CDC changes. Again, I'm not giving you a black and white, but I'm telling you things that we did for our manuals, and it was almost all based on CDC. And then, of course, we had to brainstorm between the 5 of us that are working on these manuals to say, okay, now of all this, what do we think is best practice? Because, again, nothing's ever black and white for us.
Okay, just a couple more questions, Sharon, and then we'll wrap it up. So next question asks if you can give an example of hand washing need for gloves with basic home equipment and EMR for a non-wound care patient. And so I'm not sure if you understand the question completely, and if not, we can always see if Lynn can type more information.
No, I do understand, because it's how often do you put gloves on, how often do you change your gloves, and then every time you change gloves, you have to wash your hands. You want to have a pretty specific hand washing procedure. I won't even call it a policy. Most of us combine it into policy and procedure. But that procedure part really has to be known and followed by your staff. And so if you are doing different types of procedures on the patient, with head to toe, and then picking up their stuff in their home and dealing with stuff that is kind of not too cool, or going back and forth between systems. A lot of when you change your gloves there is common sense, but the procedure would say anytime you're going from clean to dirty or dirty to clean, anytime you pick up soiled equipment or supplies in the patient's home, in between that. And then when you take your gloves, when you're going into your bag, you take your gloves off, you wash your hands, you go in your bag. When you're done with your own BP cuff on the patient, you wipe it down, then you take your gloves off, you put it in your bag in the pocket that's made for that. It's a complex system of when you do hand washing, when you change your gloves. And so to have your procedure as specific, I think our procedure is just like, and it's based on what, I looked at as a surveyor forever. It's, every time you take off your gloves, before you enter your bag, before and after wound care, so it's not a lot more than what is common sense. However, I'm a clinician. When you're in the home and you're doing patient care, it's really hard. And now we have laptops. And I was doing, in fact, Monday, I'm doing home visits all day with an agency to see how they are pre-survey. And I did them in October on them. And they were terrible with that. The nurses, they like to carry clipboards with flow sheets on and their laptop and their bag. And oh my, a lot of their patients' homes were not good as far as infection control goes. Their patients and caregivers and family were not good with infection control just overall. And so they're trying the best they can, but they cross-contaminated and could have, gotten infection control icky stuff on themselves as well. So it's not easy. The best way to do it is make sure your procedure is very detailed. I believe that our procedure that has when to wash gloves is the same as CDC. And then educate, go over it like I'm going over it with you, but in real detail with the patient's scenario. Have somebody play the patient, do a scenario, then do a competency, then do home visits, and then repeat that at least every year for every one of your staff. It's the only way. And then frequent home visits to watch for it, because then the staff gets used to people watching them do it, and it becomes more second nature instead of thinking, oh man, the surveyor is watching me, I better really make sure I do this right, and then they mess up a lot. So those are my recommendations to you.
Okay, Sharon, final question comes from Christine, and she's asking, are quarterly clinical record reviews required?
Well, they aren't anymore in the new COPs per se to say this many percentage quality record reviews of every discipline. That's gone. But part of your QAPI program, I don't know how you can do a good QAPI program without doing a percentage of your active and discharge chart as a full chart looking for everything. Then your quality indicators, you may have improving pain. You may do spot checks on who declined on pain and then have an audit tool for them. And it's very individualized and customized. But as a best practice, if you don't do full clinical record reviews on a percentage of your charts on a regular basis, I think that that's not a good idea. And then that's one of your quality indicators. But no, per se, it doesn't say that specifically. But your surveyor is going to look at the full thing. So, to me, why not look at the full thing? And then from there, you can say, ooh, boy, our following physician orders is really crummy. Maybe you want to focus more on that, but then still do 10, 20%, a quarter of random selected of different types of active and discharge charts. I would recommend as a best practice.
All right, fantastic. Those were a lot of great questions. So thank you to everyone for submitting those. And Sharon, I'm going to turn it over to you for your final thoughts.
Thanks, Patty. You said a lot of great questions. I hope it was a lot of great answers because, again, I didn't say yes or no to any of them. It's a lot more involved than that. And so I'm hoping that the tips that I gave you will help you and not confuse you more. But I really thank you for joining us, and hearing those great QAPI and infection control questions means that you really get it and that you are trying to go to that next level to be compliant and really improve your organization. So thank you, and I look forward to ending our session next week.
All right, thank you, Sharon, and to 5-Star Consultants as well, and as always to the attendees for joining us. And as Sharon said, we look forward to speaking with all of you again on February 15th at the same time, and Sharon will be speaking about emergency preparedness, compliance, and clinical records. So until then, everybody have a great day.